In this lecture, we're going to review the things that you need to do as soon as baby comes out. That is, how do you go from delivery to healthy baby in the well nursery? Neonatal resuscitation is going to be about getting baby oxygenated and making sure the heart is pumping blood through the body. Oxygenation and circulation are the primary focus of the first minutes of life. And then we'll start peeling off into some of the diseases and troubleshooting you might do and finish up with what a normal exam should look like and how it might direct you to some of the other lectures to learn about those diseases. We're going to do something a little different in this lecture, and that is we're going to use a timeline. It's not what you're probably used to at online med ed, but it makes a lot of sense for delivery of an infant. Delivery is going to be at time point 0. And you, the pediatrician, can probably be ready for baby a little bit before they come out. And so preparation is going to be crucial. And in the preparation phase, you're going to want to make sure you have your equipment. And that equipment is going to be things like towels to dry and stimulate baby, the warmer, and make sure it's on and actually warm, and then your respiratory equipment. Make sure it's all present and in working order. But you can also anticipate problems with baby. Feel that the 24-year-old G2P2 mom who has had all her prenatal care and nothing's gone wrong in the whole pregnancy is a little nicer for the pediatrician than is the 16-year-old undocumented immigrant who has had no prenatal care and actually has delivering at 22 weeks with a very small child. Right, so that's obvious. But you can prepare yourself a little bit. And you can prepare yourself by getting to know mom's gravid and peristatus, and then the gestational age, as well as any prenatal care. Anticipate problems before they arise. But as baby comes out, it doesn't matter what happened before, so begins resuscitation. And the very first thing you're going to do, that is between minute 0 and minute 1, the thing that you are going to do the most is stimulate. Stimulation is key. And stimulation is trying to overcome primary apnea. Remember, the goal here is going to be breathing and circulating oxygen. You can stimulate baby by rubbing its back, using towels, or tapping the feet. Anything to get baby to take that first deep breath. And you're going to start considering oxygenation and circulation as well. Now, in the first minute, it is okay if the pulse oximeter doesn't even get on, but you shouldn't expect baby to be better than 60 to 65%. And the way you can improve that or help baby along is by suctioning. Because babies are mouth breathers, you're going to want to suction the mouth, then the nose. This is to avoid aspiration of any meconium that happens to be on them. And if they do not respond the way you expect, the thing that you're going to do is positive pressure ventilation. Start bagging baby. And all the while, you may want to ask the question, do they need to be intubated? What you're going after here with the intubation question is secondary apnea. That is, after the initial period where baby begins to breathe spontaneously, there may be apneic episodes. If baby goes apneic, just bagging may not be enough. You may need to say, does this baby need the tube? And in regards to suctioning, usually just doing oropharyngeal suctioning is enough. If baby comes out and is doing well, that may be all you need. But if baby's not doing well, as we'll discuss in the way of the heart rate or the saturations, endotracheal suctioning may be necessary. Not everybody needs that. And we do want to give consideration to what do we do about the heart rate, because as you'll see, it's going to change over time. The goal heart rate for baby is a heart rate greater than 100. And if the heart rate is less than 100, in that first minute, remember the first minute, the emphasis is on opening up the airway and oxygenation. If baby has a heart rate less than 100, the response should be positive pressure ventilation. It is probably an oxygen problem, and so you get the oxygen level flowing up and baby being ventilated, and then worry about the heart rate in the next 5 minutes. Minute 0 to minute 1, stimulation, get the airway open. If you can't bag, that's another indication for intubation. Between minute 1 and minute 5, this is where you begin to focus more on respirations and circulation. You calculate your first APGAR score between minute 1 and 5. And the APGAR, as we'll discuss in detail in a moment, is a scoring system that has nothing to do with long-term outcomes, but it's an objective measurement to see if baby is improving in these first minutes. It's based on a score of 0 to 10, and what you want is 7 to 10. This means you can progress with standard of care because baby's doing good. Less than 7 means do something, fix that, because that's not good. And that do something. Remember, everything is about oxygenation and circulation. So as we begin to engage baby here in the first 5 minutes, as we go to oxygen, what we're looking at is to start to improve the oxygen levels. The pulse oximeter should now be between 80 and 85%. Still not normal, but getting there. And the way now you're going to improve oxygenation is with FiO2. If the respirations look good, baby's ventilating well, but the oxygen level isn't high enough, you simply need to give them supplemental oxygen, blow-by. But you may always need to consider, do I need to continue positive pressure ventilation, and does baby need to be intubated? And then heart rate becomes more of a circulatory issue. Now, again, your goal is still heart rate greater than 100. But a heart rate between 60 and 100 probably is a respiratory issue, and so what you're going to do is positive pressure ventilation. But if it's less than 60 and you have good chest movement, you know your ventilations are good and you're giving supplemental oxygen, that's a cardiac problem. Now you initiate CPR. And CPR is going to be done with 3 compressions to 1 ventilation, as well as accessing the umbilical vein to give epi. Now, I'm breaking this down into minute 1, minute 5, and minute 10. But I don't want you to see these as hard stop points of time. I want you to see them as milestones, such that if the baby needs to be intubated in the first minute and you're at minute 5, you start still here, trying to get the oxygenation and ventilation working. You're not going to just stop at minute 1 and minute 5 to reassess. And if you haven't progressed all of the milestones in that minute category, you stay in that window as you move forward. So resuscitation may take a full hour, but this is what you expect to see in the first 10 minutes. And so if you don't reach a milestone, you stay in that window, fix it, and then move forward. In minute 5 to 10 is where you're going to get your second APGAR score. And the same thing is true as APGAR 1. You want 7 to 10, or at least improvement. In the way of oxygenation, the goals and intervention don't change. You want a little bit better oxygen, that is 90 to 95%. Don't fight to get to 100, just over 90 is fine. And you're going to get there using FiO2 and positive pressure ventilation. The heart rate becomes essentially the same thing. As before, you want over 100. It's a respiratory issue if it's 60 to 100, start a code if it's less than 60. So I want you to see what we did. At the very beginning, what we cared about was opening up the airway and getting ventilations going. In the first 5 minutes, we cared about maintaining oxygen levels, and that's primarily the focus was still oxygen, but also start to incorporate the heart rate. In minute 5 to 10, we're trying to see an improvement of the APGAR score because we're pretty sure we've already got this oxygen and cardio stuff taken care of. We want to see baby improve. If baby does not improve and resuscitation continues, you will continue to do APGAR scores. You'll continue until you get to a 7 or 10, the oxygenation is good, and the heart rate is good. So what is this APGAR thing? Well, APGAR is itself a mnemonic. And the APGAR is scored from 0 to 2 on 5 different categories. And the categories are appearance, pulse or heart rate, grimace, activity, and respirations. You get 2 points in each of these categories for being a normal baby. What you should look for in appearance is a pink baby, showing good oxygenation. The heart rate should be over 100. The grimace should be achieved with very little stimulation. Activity, the baby should be able to resist extension, not just flex, but resist extension and give some resistance back to you. Now, of course, you being the adult are going to be able to overcome baby, but there should be active contraction. And respirations are going to be strong and regular. Looks like a normal baby. After your third delivery, you'll be able to recognize what that is. You get 0 if baby's doing poorly. The appearance is going to be blue. A cyanotic baby or someone who's very pale gets no points. The pulse gets 0 points if it's absent. The grimace gets 0 points if it's absent. The activity gets 0 points if there's no activity at all, and respirations get 0 points if they are absent. It is not hard to diagnose a baby as having a score of 0 because it's simply not there. 2 is that looks like every other baby I've done. The trouble is that on the test, what you're going to have is a bunch of 1s, and you're not really going to be sure if they're 1 or 2. So look for key words. Appearance, you look for the word acrocyanosis. It's an easy way to say they only get 1 point, but they have cyanosis in there, so you might think it's a 0. The heart rate is present, but less than 100. The grimace can be achieved, but it requires a lot more stimulation than you expect. That's hard to say in the vignette, so generally they don't have that. The activity level is that they're able to flex, but not resist extension, and respirations are present but irregular. So the way the test is going to get you is on acrocyanosis, the heart rate, and irregularity of the respirations. It's an easy way to subtract points, and because you'll be able to see 0 and 2. If you came to minute 10, and as most babies are, they're doing great. Right? Only 10% of deliveries actually really need you to get involved, and only 1% are going to require aggressive measurements like an intubation. And generally, you know that's coming because they're premature. So most of the time, by the time you get to 10 minutes after APGAR 2, you can just do the standard of care. And we'll talk about that in a moment. But as you continue to resuscitate, you may encounter some problems. Now, a lot of these problems are covered in other pediatric videos like PED-CT. So let's cover some of the diseases that aren't covered anywhere else that you might encounter initially in resuscitation. The first 2 are that of oxygenation. That is transient tachypnea of the newborn and respiratory distress syndrome. Let's talk about transient tachypnea first. The pathogenesis here is that it is self-limiting. And it is a problem, essentially, that baby didn't get squeezed through the birth canal right. Usually we help mom out, and then baby doesn't breathe normally because it wasn't properly stimulated by mom's contractions. So it's most often seen in C-sections. But transient tachypnea of the newborn, that self-limiting process, is generally going to be a term baby or near term. Right? They're healthy otherwise, but they just have some respiratory problems. So they're grunting. And that is them effectively performing their own CPAP. The diagnosis is going to be made on a chest x-ray, which is going to show you hyperextended lungs. And the lungs are hyperextended and wet. This is telling you that all the baby needs is a little PEEP, and you do that with positive pressure ventilations. This usually goes away in the first 6 hours, but can persist up to 48. That's usually while you and your attending will have this discussion. On the other hand, a respiratory distress syndrome is going to be a real problem. This is not self-limiting, it is developmental. And there's been insufficient surfactant to develop the lungs. So this is almost always going to be in a very severe premature infant who may have been delivered because of perinatal distress. Right? It is a baby who's not doing well to begin with, who comes out too soon. And here's the major difference. You're seeing the difference between term baby and transient tachypnea and premature and respiratory distress. And then you'll notice the difference in the chest x-ray, which shows hypoextended lungs with atelectasis. Transient tachypnea, just a little edema. All you got to do is some PEEP and you'll be fine. Respiratory distress, you've got collapsed lungs that won't open. Now you need to do an intubation and maybe give surfactant. Before we talk about normal and how to get dispatched off onto the other diseases or other videos, the last thing I want to talk about is hypoglycemia. And hypoglycemia is a major problem because if you're just hypoglycemic a little bit, it's associated with worse outcomes for baby in development. And baby can get hypoglycemia, those who are at risk. There's a whole bunch of things, right? It's going to be those who are large for gestational age and those who are small for gestational age, those who come from diabetic moms, and those also who have intrauterine growth restriction. So basically, it's any baby who's abnormally sized or has an issue with glucose at all from mom or during pregnancy is at risk for hypoglycemia. Now, patients may be completely asymptomatic. That is, you check their blood sugar and they have no problems. Or they can be full-blown symptomatic, which is going to be jittery, tremors, and it may progress to seizures. Lethargy is a baby's coma. So jittery, tremors, lethargy, or seizures is an indication of hypoglycemia. Now, it's not going to be a mystery diagnosis that their blood sugar is low. You check their blood sugar. But what you should do is recognize that this could be potentially from sepsis, so you should be looking for causes of infection. We cover these primarily in the OB section where we talk about perinatal infections. But the important thing here is you're not really going to spend time figuring it out. You're just going to fix it. Right? So in that newborn setting, if the baby is asymptomatic, you can simply have it feed. If it can't feed or it is symptomatic, then you're going to give it an IV bolus of sugar. You give 2 mils per kg of D50. If it persists, that is, it is recurrent despite infusion of D50, now you're going to set up a drip, D5 or D10, and constantly infuse sugar to keep it high. So before we move on to talk about the well baby visit and use that as a jumping off point for us to talk about other lectures you should look at in the very near period, we're going to review the timeline. When baby is delivered, the goal is to stimulate to overcome apnea, primary or secondary, giving, suctioning, or positive pressure ventilations. Even if you have a problem with the heart rate, the focus is on the airway. In the first 5 minutes, you move from just get the airway to ensure oxygenation, and if it gets getting really bad, start CPR. CPR is 30 to 1, epinephrine to the umbilical vein. As you push to minute 10, the emphasis becomes more on is baby improving in the way of the APGAR scores because you've already intervened with pressure, FiO2, and cardiovascular support. As you get past minute 10, baby should be doing well, moving on to standard care. Keep an eye out for transient tachypnea of the newborn and RDS. Transient tachypnea of the newborn is a near-term grunting, hyper-extended and wet. All they need is a little positive pressure ventilation, a little bag, or respiratory distress syndrome, which is a premature infant, hypoextended lungs, atelectasis, they need intubation. And if their blood sugar is low, give sugar. Let's round this lecture off by talking about the well child visit and what can go wrong. So what is standard of care? Baby comes out of mom, is easily resuscitated, and dried off. It's a happy fat baby, everything's going well. Now you come into the nursery and say, well, baby's out, safe, let's do the things we need to do. The first thing you're going to do is measure baby. You want weight, length, which is baby's height, and head circumference. The second thing you want to do is look at the cord. You want 2 arteries, 1 vein, and you want to clip or clamp that cord close to baby and remove excess. The third thing you're going to do your shots and drops. Baby needs a dose of vitamin K because the gut flora is incapable of making vitamin K. This prevents hemorrhagic disease of the newborn. And you're going to consider hepatitis B. Whether or not you give the vaccine, IVIG, or both based on mom's immune status. We talk more about that in the vaccination lecture. For the eye drops, you're going to use conjunctivitis prophylaxis. Do not use silver nitrate because that's going to cause chemical conjunctivitis. If you have to pick, use erythromycin. And if you have to treat something because of maternal risk, it's going to be disease specific. That is going to be in our optho lecture. And then you're going to turn your attention to baby. You're going to start the scalp, making sure the fontanelles are appropriate, that is, not sunken and not bulging, and look for hematomas. You're going to do the red reflex in the eye, assessing for retinoblastoma. Talk more about that in the optho lectures. As you come down to the mouth, you're looking for cleft lip or palate. Talk about that in the congenital defects lecture. You're going to feel the bones for crepitus, especially the clavicles, to assess for a fracture. The biggest thing you can do to identify early diseases is looking for murmurs, which we'll discuss in pediatric CT, noting that a PDA may not be audible on the first day, and also abnormal lung sounds, such as bowel sounds in the lungs. Talk about that in the congenital defect lecture as well. You're going to assess the cord, and this is going to give you an idea if there's a bowel problem, such as gastroschisis or omphalocele, congenital defects lecture. You want to assess the genitalia. To gender the baby, and also look for any defects that might need to be fixed. Specifically in males, the hypo or epispadias, which are going to prohibit your circumcision should mom want that. You're going to look for an imperforate anus. Because this may give you clues to the Vactrel syndrome. Check out failure to pass meconium. You're going to assess baby's skin for jaundice, and you can look at neonatal jaundice lecture. And you're going to do the Ortolani and Barlow maneuvers to give you any indication of orthopedic problems, and you can see Peds Ortho for more on that. All right, so as you come through here, there's a lot of stuff that's going to happen. Most of it is checklist driven. But I want you to see that after initial resuscitation, which is oxygenation and circulation, you then want to come to try to identify the problems that baby might have. Do the interventions you need in terms of shots, drops, and clamping the cord, but then also begin on the first day, day one, to identify any problems or congenital defects baby might have. And this is what's scattered all over the pediatric content. Most of what we deal with in this course is going to be very early on disease, not necessarily that, but which happens later in life. That is neonatal resuscitation and APGAR.